Into this explainer and decode exactly how clinicians systematically map the human body to solve some seriously complex medical mysteries. You know that feeling when you're sitting in a doctor's office, filling out endless forms and answering what feel like totally random questions? You probably wondered, where does all this information actually go? Well, today we're going to unpack the actual standardized assessment forms medical professionals use every day. We'll see exactly how they take your everyday symptoms and translate them into a literal scientific roadmap for recovery. It's fascinating stuff. Think about it. Before any actual treatment even begins, clinicians are basically acting as medical detectives. They're gathering this incredible array of clues to pinpoint exactly what's going wrong. And they absolutely don't just guess. They use highly structured, rigorous frameworks to trace the true source of your pain and dysfunction. Honestly, every single tick box, every measurement, every little observation, it's all designed to systematically eliminate possibilities until the true culprit is finally revealed. To understand this exhaustive investigative process, we will look at 4 distinct sections today. Section 1, musculoskeletal mechanics. Section 2, mapping the nervous system. Section 3, evaluating cerebral palsy. And Section 4, from clues to care. Starting off with Section 1, musculoskeletal mechanics. Every standard musculoskeletal assessment follows this really rigorous, universal, step-by-step progression. It goes from taking your story to actively testing your physical limits. It always starts with the history, literally just listening to the patient. Then comes observation, where they're looking at things like your posture and your gait. Next is palpation, which just means physically touching the affected areas to feel for things like swelling, temperature changes, or tenderness. And finally, the examination. This involves active tests of your strength, your range of motion, and your reflexes. Basically, it's a structured funnel that slowly narrows down the diagnosis. Now, notice how the investigative paths immediately diverge to capture very different types of historical clues, all based on how your injury actually started. If you come in with a traumatic injury, let's say a fall or a car accident, the assessment zeroes right in on the inciting trauma. Specifically, they want to know the direction and the magnitude of the physical force that hit your body. But if your pain is non-traumatic, the detective work completely shifts gears. The clinician instead traces the sequential process of your symptoms, what primary treatments you've already tried, and exactly how the pain has evolved over time. 2 entirely different investigative paths, right from day 1. We all know pain is super subjective, right? But by using tools like the visual analog scale, clinicians can pin down an exact, measurable baseline. It ranges from no pain all the way to worst possible pain. By simply asking a patient to point to where their pain falls on this line, doctors are able to convert an invisible, completely subjective feeling into a concrete, usable data point. And that's absolutely crucial because it allows them to accurately track whether an intervention is actually working for you week after week. Moving right along to Section 2, mapping the nervous system. When evaluating the brain and nerves, the crucial point to remember is that consciousness isn't just a guessing game. It's rigorously calculated using objective responses to stimuli, commands, and speech. Enter the Glasgow Coma Scale. It's this brilliant standardized tool that gives a patient a score out of 15. It evaluates 3 very specific areas: eye-opening, motor response, and verbal response. So, for example, if a patient's eyes open spontaneously, they score 4 in that category. If they can follow motor commands perfectly, they get a 6. This system creates a universal language, meaning any doctor or nurse can instantly understand the precise level of a patient's brain function. But it goes beyond basic consciousness. The investigator also tests the actual processing power of your brain, evaluating memory, vision, and some really complex cognitive functions. They aren't just asking how you feel, they're literally actively testing your hardware. Clinicians will check your information and vocabulary, your calculating ability, your abstract thinking, and even your constructional ability, which, by the way, is your brain's capacity to understand spatial relationships and draw or build objects. It is a total, comprehensive audit of your cognitive circuits. Then we have the modified Ashworth scale, which beautifully illustrates how a physical symptom like muscle spasticity is formally graded. It goes from no increase in tone all the way to a limb being fixed in a rigid posture. You see, in certain neurological conditions, muscles can become hypertonic, meaning excessively stiff. This scale allows a clinician to passively move a patient's limb and actually grade that resistance. A 0 means normal tone, a 1 means a slight catch at the end of the movement, and it scales all the way up to a 4, where the limb is just completely rigid in flexion or extension. Again, they're taking a feeling and turning it into a measurable clinical fact. Now for Section 3, evaluating cerebral palsy. For pediatric care, especially with highly complex, multi-system conditions like cerebral palsy, assessing an infant requires an entirely different approach. A key clinical directive here is that over 80% of the assessment is purely observational. Why? Because natural play reveals far more clues than forced clinical tests. I mean, you can't exactly ask a 6-month-old to rate their pain on a scale from 1 to 10, right? Or ask them to perform a specific motor test on command. Instead, the clinician creates this playful, unhurried atmosphere. Just observing how an infant naturally reaches for a toy or how they move their tiny body against gravity while sitting on their parent's lap, that is vastly more diagnostic than any intrusive handling. Because infants can't speak for themselves, the history gathering phase here is incredibly extensive. They're looking for any physiological disruption that might have happened before, during, or after birth. The clinician investigates the entire developmental timeline. Prenatally, they look at maternal age, potential infections, and genetics. Perinatally, so right around the time of birth, they record the birth weight, the specific type of delivery, and APGAR scores, which are those quick health checks performed right after delivery. And postnatally, they note any NICU stays, early trauma, or even feeding difficulties. Literally every single variable in that timeline is a potential clue to a neurological delay. And they meticulously track key developmental milestones, specifically to identify the exact moments a child's gross motor functions might be delayed. They rely on standardized benchmarks. For instance, at 4 to 6 weeks, they're looking for a social smile. By 5 to 6 months, a child should be sitting without support. Around 13 months, walking without much support, and by 3 years old, they should be riding a tricycle. If a child is missing these critical transitions, it's a huge red flag that pinpoints exactly where therapeutic intervention needs to begin. It's actually fascinating how specific this checklist gets. Doctors analyze everything from how a child transfers a toy between hands to the actual physical mechanics of eating a meal. When looking at fine motor skills, it's not just about, hey, can they grab an object? It's about bimanual manipulation. Can the child use both hands together effectively? And when it comes to the oromotor examination, things like chewing, swallowing, and even messy eating are key clinical indicators. Actually, messy eating can point directly to an underlying lack of coordination in the facial and mouth muscles. Who knew, right? Which brings us to our final part, Section 4, From Clues to Care. Finally, we reach the conclusion of the investigation. All of this exhaustive data we just talked about must be synthesized into an actionable plan. All those pages of checkboxes, medical histories, and scales culminate in these specific goals, turning the collected clues into a highly targeted roadmap for the patient's recovery. The very first thing the clinician does is create a problem list. But crucially, and the assessment notes really highlight this should not just be a copy-paste of the patient's complaints. No, it's an analysis of the actual impairments and limiting factors. From that problem list, they derive short-term goals for the next few sessions and long-term goals aiming for ultimate functional independence. So, given the incredible complexity of tracking every reflex, joint, and milestone, how much more appreciation do you have for the science of understanding the human body? The next time you step into a clinic, remember that every single question you answer and every little movement you make is a vital clue in this incredible medical detective process. It's not just annoying paperwork. It is a meticulously crafted algorithm designed to understand your unique physiology. I really hope this explainer gave you a brand new perspective on the science behind medical assessments.